Greetings, everyone. So this talk will cover the surgical management of an infected diabetic foot. It's not much different to an infected foot without a background associated diabetic pathologies, but there are some specific principles we're going to cover through this presentation. Now, we know that the prevalence of diabetes worldwide is very high at present. The darker the country in that map on the left side, the greater the prevalence of diabetes in that population. And that is expected to become even more darker in the coming decades. So the burden worldwide is already massive, and that is going to get even more greater in the coming years. So if you look at the statistics of diabetic foot disease worldwide, the lifetime risk of a person with diabetes developing a foot ulcer has actually gone up to about 35% since the previous assessment that was done more than a decade ago. The problem with these foot ulcers is that a number of patients with diabetic foot ulcers develop problems that eventually result in an amputation. But about 80% of these amputations in this group of population is actually preventable. And that often starts with an infected diabetic foot. The mortality, you may think that we can simply do an amputation for such presentations, but unfortunately the mortality following amputation in a person with diabetes is very high. So that may not be the correct solution. If you look at the mortality rates at 5-year time in various diabetic foot-related pathologies, in comparison to the most celebrated, most discussed common cancer, the breast cancer, which carries about 10% of 5-year mortality rate, simple ulceration in a person with diabetes shoots up the mortality rate to around 30%, and a minor amputation to well above 40%, and a major amputation much greater than 50%. In fact, the most recent studies have revealed that the 5-year mortality rate following a major amputation in people with diabetes is around 80%. And you can see, lung cancer is known to have very high mortality rate, but diabetic foot conditions, in fact, far exceed many common cancers. Yet they don't receive enough attention. And in fact, every 6 seconds, a person with diabetes dies worldwide. So if you look at the conditions in a diabetic foot that eventually lead to an amputation, can be related to vascular infections or even deformity. But this talk will cover all aspects of infection-related presentations. So this talk will focus on the surgical management of an infected diabetic foot. And the components of that management include diagnosing the infection, assessing the severity of infection, and delivering appropriate surgical intervention when required. So let's focus on the diagnosis of infection. I don't have to repeat some of these important points, but by and large, a foot infection in people with diabetes present with a warm and swollen red foot with or without ulceration, and there are certain conditions that present similarly, such as gout or deep vein thrombosis or Charcot. Those need to be excluded. But by and large, if there is any skin breach, one needs to consider a diabetic foot infection. So for diagnostic purpose, if that infection is predominantly soft tissue, then certain routine investigations, including blood investigations and imaging, are helpful. But if you suspect a deep infection or osteomyelitis, in addition to diagnosing the presence of such infection, it's really helpful to obtain microbiological diagnosis through appropriate biopsies or deep tissue samples. And we can't emphasize enough the importance of taking bone biopsy specimens from a suspected osteomyelitic area. That will not only confirm the diagnosis, it will also actually help you, deliver appropriate treatment. Now, this is a PDF presentation. We have a bit of technology glitch. We can't share the PowerPoint presentation, but here we can see that from this study, the deep swab specimens have been proven to provide much greater accuracy in the diagnosis of the deep infection from the diagnosis point of view, and also from the microbiological point of view. There are a number of guidelines. One notable one is the International Working Group guidelines on the diagnosis of a diabetic foot infection, and very recently D-Foot International has provided a very simple 5 steps to manage an acute Charcot in comparison to infection. So when you make a diagnosis, then we assess the degree of severity of that infection. And this presentation can be in the form of a simple chronic infected ulcer, very long-standing ulceration with recurrent chronic infections that may not require emergency attention, or it can present an acute infection, a chronic ulcer that acutely gets infected, or an acute de novo infection, or occasionally as a diabetic foot attack. Diabetic foot attack is a rapidly spreading local, spreading infection. So depending on the severity of that infection, it is really critical that we grade that severity based on the presentation, so that some presentations can simply respond to antibiotics and bedside debridement, such as a chronic infected ulcer with no deep penetration, or some require surgical debridement and antibiotics, and some of that surgical intervention can be even emergent surgery, such as for a diabetic foot attack presentation. But when you consider surgery, whether it is a local debridement, bedside debridement, or a major infection control surgery, the key intervention is the surgical debridement. And again, this talk will cover a lot of those principles. It's absolutely critical that the quality of the surgical debridement in a person with diabetic foot problems is of top class. In order for us to make sure that we follow these the debridement principles adequately, we tend to use this RAG model, red, amber, green model. Red means that is the zone of necrosis where the infection is very active with a lot of tissue necrosis. So dead tissue with active infection, that is the red zone. But that is surrounded by the reactive zone, the amber zone, which can be quite wide in some infections. This example of diabetic foot infection, in this patient, there were multiple episodes of infection exacerbation. The longer the duration of that ulcer with higher numbers of infection recurrence, the greater that zone of recovery, or amber zone. And you can clearly see that after excision of the ulcer, when you extend the dissection, you can see a very large area of amber zone. All of that needs to be excised so that you're down to the green zone. And that is the zone that can show healing response. So it's critical that you reach that area. Again, because of the PDF, we can't go through all the images, but you can clearly see the degree of infection here, quite extensive necrosis, quite a wide area. The surgical debridement has to be very aggressive, excise all of that infected tissue down to the green zone. And any residual areas can be debrided through bedside debridement. There is a small area of necrosis, that's not a problem. And then with vac dressing, in this case example, you achieve good granulation response, and you can do skin grafting in the end to achieve full cover. So even in a different presentation of diabetic foot infection, in this example, there is massive redness here in the whole foot, and also the whole foot is swollen. There is an ulcer with discharge and evidence of tissue necrosis. And this erythema on this presentation has been spreading rapidly, and there is local warmth, and the patient is also systemically unwell. Such type of presentation that essentially spreads very rapidly is called a diabetic foot attack. And this term of diabetic foot attack was introduced relatively recently, and it is gaining a lot of attention because these presentations require that type of very notable attention. So because if you delay the treatment, usually in the form of surgery, there will be more tissue loss. So spreading infection, local tissue necrosis, and systemically unwell presentation is a diabetic foot attack unless proved otherwise, and that is similar to the MI, in myocardial infarction of the foot or CV of the foot. So here, earliest intervention is critical. So we don't spend too much time on doing extensive investigations. Clinical presentation should draw to your attention. So in this example of diabetic foot infection with local tissue necrosis, and the other images which are not visible in this PDF format showed initial early debridement through the red zone, but the infection has spread, and that required further 3 repeated debridements. Finally, adequate debridement into the green zone that resulted in predictable healing response. So what happens in diabetic foot attack presentation is that some minor injury, usually very, very tiny scratch or blister, gets infected, and that ulcerates. But with this presentation, the infection spreads very rapidly, resulting in spreading cellulitis and systemic response. And the tissue necrosis spreads, and that leads to microvascular occlusion, and that also promotes rapid progression of that infection. So that requires a very rapid arrival of diagnosis. And now we are all becoming familiar with this particular type of presentation, the diabetic foot attack. That itself draws a lot of attention, and hopefully we will not miss such presentation when that happens. It's critical that we culture the bacteria responsible for that infection and start empirical antibiotic therapy, intravenous therapy, based on the local cultures in that region, and then wait for the microbiology results. But meanwhile, if there is significant tissue necrosis, you should proceed with surgical debridement. So the surgical debridement, again, we can't see all those pictures. That explains that there are extensive infection. The infection spreads along the tendon sheaths. The tendon sheaths are called superhighways of infection, and you have to really explore all of that area. So all red and amber zones have to be excised. And on this occasion, for this patient, 2 more debridements were done. But once we saw beautiful granulation tissue response, skin grafting was done. Another example of diabetic foot attack, again, adequately debrided, good granulation tissue response, and skin grafting. So just to recap, if the diabetic infection is associated with spreading redness, significant local warmth, and large area of swelling, with or without ulceration, but with evidence of tissue necrosis, and the patient is systemically unwell, one has to give this an immediate attention, because this is a diabetic foot attack presentation, and that appropriate principles are followed. However, outside those presentations, very simple diabetic foot infections, diabetic foot attack. Then coming to the third type of presentation, the diabetic foot osteomyelitis, where the infection has gone deeper into the bones. Now, these patients require a specific treatment regime. If there is a deformity that might need attention, if there's no deformity, that might require just simple diabetic foot osteomyelitis treatment. But the principles are exactly the same. If you look at this example, this doesn't have significant deformity. There is some deformity we conceive based on the calcaneal pitch angle. But the main problem here is that there is a large exostosis resulting in point loading in that part of the midfoot, promoting ulceration, and with recurrent infections, very large area of infection, local infection in that area. So there's no doubt that on this occasion, the probe to bone test was positive, and there's clear evidence of osteomyelitis in that area. So this requires aggressive soft tissue debridement using the RAG principles I mentioned earlier. Here, there is rocker bottom deformity. A midfoot reconstruction would be ideal, but this patient was not keen for such major surgery. but you still like to correct that plantar equinus deformity here. So that requires percutaneous Achilles tendon release so that you can bring the calcaneal pitch back to normal. So following aggressive debridement, you can see the size of the soft tissue defect there. The bone prominence is gone, and the foot is plantigrade, and with vac dressing and targeted intravenous antibiotics, the wound healing response was predictable here. Whereas if the foot infection presents with associated deformity, that requires a different form of attention, and they come in all shapes, all severities, and they do need personalized attention. But we'll go through the principles, and my sincere apologies, because with this PDF page you can't see the full spectrum of the presentations of this particular diabetic foot infection with deformity. Basically, in this very active lady, she developed a simple ankle fracture that was very well treated with appropriate internal fixation, but unfortunately that failed. The fixation had failed, and then she had undergone an ankle fusion that also failed, and then fusion metalwork was removed, and a frame fixation was done along with debridement of potential infection, and that did not result in bone union, and that was changed to a hindfoot nail, which is an appropriate device, but somehow that did not unite either. So, and then she was left with a totally infected hindfoot nail with pus pouring out from the incisions in pin sites. So these type of presentations where there is deformity, there is the instability and active infection, those type of deformities require specific regime if you want to achieve functional limb salvage. Means not just saving the limb, but the limb function should be restored so that the patient can return to normal weight bearing. In the background of that principle, I would like to emphasize that the surgical reconstruction of a non-infected Charcot foot is unlike what was thought in the past. Until about a decade ago, this was not considered as a successful, appropriate surgical treatment. But now we know from our, from the recent studies that a non-infected Charcot foot reconstructions are highly successful. We know that, but we're talking about infected Charcot foot reconstructions. So non-infected Charcot foot reconstructions are have got reasonably predictable outcomes, and we have plenty of literature to support that. But when it comes to deformed infected Charcot foot reconstruction, we need to achieve stable fusion as we do with non-infected Charcot foot reconstruction as well, but at the same time totally infection-free environment. Otherwise, your fixation technique, whatever you use, won't be successful. So I would like to say that the first target to achieve is to eradicate infection, and then you can proceed with stabilization to achieve full and permanent deformity correction. And we have shared our experience, and our series has been submitted has been accepted for publication in this particular journal. But let us share our experience. So basically what you need to achieve is eradication of infection first, followed by deformity correction. So the first stage of eradication of infection requires aggressive surgical debridement of that infection, whether it is an ulcer or a simple deep infection. But it's really critical that you obtain the microbiological diagnosis by obtaining deep tissue specimens during the procedure, doing bone biopsies during the procedure, using very regimental principles so that there's no contamination. It's really critical that you achieve that microbiological diagnosis. And when you do aggressive bone debridements, the foot will become wobbly, unstable. You can't leave it like that. You have to provide stability, and you can achieve that stability by using guided, threaded guide wires or an external fixator. It doesn't matter. So, but at this time, based on the previous bone biopsy results, you can apply local antibiotic delivery solutions such as STIMULAN. And in this example, you can see this STIMULAN through the wound. And another example of debridement and applications of stimulant, and the antibiotics chosen based on the bone biopsy specimen results. So I would like to just to many of you are probably aware of the way stimulant is prepared. Basically, it comes as a calcium sulfate powder, and you add fluid to it, and then antibiotic. And there's a specific recipe for each antibiotic you can use, and then those pellets are inserted into the bone gaps or in the soft tissues. Then we still use targeted intravenous antibiotics to achieve infection eradication, but the large wounds that are left with are managed with appropriate advanced wound management treatment. But we most of the times it tends to be a negative pressure wound therapy in our unit. So what we're trying to do here is to achieve infection eradication first, and then reconstruct later. So during the second stage, you do the full reconstruction. So it takes about 6 to 8 weeks before you feel that you are ready for the second stage. So you wait for progressive normalization of CRP, and it stays down below a normal level, and clinically the wound healing response will remain optimal, and the blood sugar control remains optimal. And once you achieve that infection eradication status, you can proceed with the internal fixation or external fixation technique, whatever technique you fancy. So the same case example I mentioned to you earlier, who had 4 different surgical procedures done, and that unfortunately had failed through infection and metalwork failure. So you can see in this example, that was the failed hindfoot nail, infected hindfoot nail radiograph before surgery, and all of that metalwork was removed. Extensive debridement using the rack principles, very aggressive debridement, and then pack the bone voids with stimulant, here on this occasion with vancomicin. Then temporary stabilization on this occasion with threaded wires, and you can see the wire sides look good. The open wound has healed beautifully with vac dressing, and swelling has come down, CRP is down and normal. And once you're happy, then you can go back in and achieve permanent stability and permanent deformity correction. That requires the internal fixation technique. On this occasion, in different case can be an external fixation, but we use internal fixation more often because our patients tolerate this much better. So you have completely infection-free environment, so you can expect a good healing response, as it was in this patient. The patient was able to commence normal mobilization. So another case example, this patient who had pancreas renal transplant a few early, before she developed bilateral Charcot deformities that developed infection. And in fact, local team had done a hindfoot nail on the left side for this type of non-traumatic ankle fracture, which means Charcot, with midfoot Charcot change as well, hindfoot nail that got infected, whereas on the opposite side, midfoot Charcot initially reconstructed using certain metalwork construct, but that had failed and then got infected. And on the right side, with such a large actively infected area, and on the left side, you can clearly see there is infection along the nail. So let's address the infected left hindfoot nail, and remove the metalwork, and again thoroughly debride and pack with stimulant on this occasion, again temporarily stabilized. But interestingly, she did develop nice stable fibrous union, so that we didn't have to proceed with the second stage. Whereas on the right side, the metalwork was removed, and you can see the amount of debridement needed. All of that amber zone had to be excised, the exostectomy to remove all of that potentially infected bone, and wedge resections as well to correct the deformity. That decompresses the soft tissues beautifully, and put the stimulan in the bone osteotomy site, and then nicely compress the fragments and stabilize with threaded wires. Primary wound closure on this occasion, but it all depends on how if you have achieved full infection clearance through surgery. And then during the second stage, again, prepare the joints, align the bones optimally, and achieve this principle of long segment rigid fixation with optimal bone opposition. It is critical that we achieve nice compressive fixation so that the bone healing response is predictable. So I would like to summarize that when you are faced with an infected diabetic foot, the first step is to achieve a correct diagnosis. We're not talking about simple diagnosis of the presence of an infection or not. We also need to have a bacteriological diagnosis. That's a very powerful piece of information regarding that presentation. Then assessment of the severity of the infection based on the involvement of the soft tissues and the bones. We should also assess the associated vascular component, which, if there is, needs to be addressed appropriately, and also if there is any associated soft tissue and bone deformity components. And the surgical intervention will be based on your assessment, and the aim is to achieve infection eradication, not just infection control, infection eradication, so that that treatment becomes permanent. And at the same time, the associated vascular compromise needs to be addressed as well. If there is deformity, that needs to be corrected as well. If there is any soft tissue contractures, they need to be balanced as well, which will not, we're not discussing in detail in this particular presentation because we are focusing on the infection aspect. So just to again reinforce the message, so the key ingredients of successful reconstruction of a deformed, infected diabetic foot is number one, to achieve infection eradication, which is critical using the principles I told you earlier. The RAC principles are extremely helpful to keep reminding ourselves. And deformity correction is a very powerful adjunct. Deformity correction, it decompresses soft tissues, and it also improves the healing ability of the soft tissues. And at the same time, it allows the patient achieve ambulatory status, so that ultimately we achieve solid bone fusion, so that that correction becomes permanent. So with that, I would like to thank you all for your attention, and we are happy to take any questions.
Thank you very much for sharing your practice of treating the infected foot there, Venya. We do have some questions. I'll just make my way through these here. At what stage of treatment would you decide to use STIMULAN?
Sure. Yeah, during the surgical debridement, ideally, you would have obtained the microbiological results, and you would have known what organisms or what pathogens are responsible for that infection. And then you proceed with surgical debridement, and during the debridement, based on the microbiological sensitivities, you will decide which antibiotic you're going to add to stimulant, and use the stimulant in the bones or in the soft tissues wherever that infection location is.
Thank you. We have another question around debridement. Debridement seems key to eradicate infection. How do you know when you've done enough debridement? Is it always until you see fresh bleeding tissue?
Very good question, and yes, indeed. So first, we start the debridement with excision of the infected and necrotic tissue, the red zone. That's where you start with. And it may not be very a beautiful uniformly round area. It's very, very irregular shaped, with multiple penetrations in different areas. So you will identify all of that area, you excise that, and we tend to take a deep tissue specimen from the middle of the infection and also from the periphery. Then you will enter the amber zone. The amber zone is the size of that amber zone is so variable. In an acute presentation, you will see very little amber zone. In an acute shock or diabetic foot attack, there is not enough time for the limb or body to try to contain that infection. So there won't be enough amber zone. But in chronic repeated infected ulcer presentations, the amber zone can be very, very large. You need to keep dissecting, keep going in all these different lanes until you reach the green zone. And as you mentioned, that feels normal, that looks normal, it bleeds normally. So whereas the amber zone one, it comes with very, very variable texture with multiple areas of scarring, necrosis, and tiny pockets of infection here and there. All of that needs to come out because that amber zone tissue cannot heal predictably. Very good question.
You mentioned a vac dressing being used. How else would you dress an open wound, particularly if you have it, if you have STIMULAN in situ?
We, in our unit, we don't really give that much importance to the specific modern dressings. So most of these patients, if you don't use vac dressing, depending on the exudation, if there is a lot of exudation, you use certain type of dressing to address an absorbent dressing. But if there is not a excessive exudation, you can use simple standard non-antibiotic dressing, and we don't give so much importance to that antibiotic loaded or certain type of dressings. No, we use just standard dressings.
Thank you. We have another STIMULAN related question. Do you use STIMULAN for a simple diabetic foot infection, midfoot or first toe?
Midfoot, sorry, say that again, please.
Do you use STIMULAN also for a simple diabetic foot infection, midfoot or first toe?
Yeah, both of them. So midfoot, yes, you generally have a very large area, and the area this area of that infection zone tends to be a bit larger, so you can apply quite a bit of STIMULAN into that bone void. In the forefoot or isolated toe involvement, the area can be smaller, so you won't be able to pack it too much. But both are equally can be equally benefited from STIMULAN usage.
Thank you. Looking at one of your slides with a diabetic foot patient, your use of STIMULAN in soft tissue adjacent to bone. Do you advise all patients to offload for better healing?
Oh, it's really critical. Again, because we are focusing predominantly on the infection surgery, I haven't covered very much on the offloading. It is absolutely critical. And the offloading, the type of offloading and the duration depends on the type of pathology we are dealing with. Certainly, if that includes deformity correction and temporary stabilization with the wires, the patient has to be there has to be total offloading for several weeks. If it is a simple exostectomy through a smaller open wound, and if it is not in the real weight-bearing area of the plantar surface, then you don't need to offload for such a long period. And there's a very important question. It's absolutely critical that we offload for appropriate duration of time.
And I think we've got one more question here. With the COVID pandemic forcing patients to wait longer for treatment, has your practice changed in order to accelerate the patient's pathway to save more patients losing digits and limbs?
Yeah, it is really, really sad that we are having to go through the kind of difficulties of the pandemic. Now, we have a very large diabetic foot clinic, perhaps the largest, one of the largest in Europe. And we have an open access clinic. We are the only open access diabetic foot clinic in the country, means we attract a lot. And in addition to that, we are the tertiary referral center for diabetic foot deformity corrections, a quaternary referral center. So we do have a large group of patients waiting to have surgery done. Some are not so time critical. A non-infected Charcot deformity correction can wait for a while, whereas an actively infected deformed Charcot foot is a relative urgent procedure. And we are struggling with theater access because of the current change in our current priorities. But what we are doing here to mitigate those circumstances is that we have established a minor procedures theater. We have 2 minor procedures theater that were built very recently, and we have had these plans for more than a decade. But fortunately, they've been built very recently. So, and using, we are able to treat trivial lesions very effectively, very quickly. We're able to do more complex debridements, bedside debridements in our minor procedures theater. We're also able to treat certain forefoot mutilating surgeries that don't require general anesthetic. But that won't solve this all problems we are currently faced with, which are massive. But I think that change in our approach has provided slightly better access to some of those long waiters.
Okay. We have a couple more questions relating to the practical aspects of sometimes you have to change the dressing daily. How do you manage that if you have STIMULAN in the foot?
Yes, if STIMULAN beads fall off, that's it. That doesn't concern us. Okay. So the surgeon has the best opportunity to apply the STIMULAN beads in the most stable environment. If there are any bone voids, we like to really fill that bone void gap quite tightly with the STIMULAN beads, and then apply the threaded wires in a compressive manner so that the beads don't fall off. But it doesn't matter if as every time when we change the dressing, a few beads fall off. That doesn't matter. So as long as the rest of the beads inside in the tissue keep eluting local antibiotic, that's perfectly fine.
Okay. Another question relating to the type of dressing. If you use STIMULAN and negative pressure simultaneously, what pressure range do you maintain for the VAC dressing?
Sure. Now we don't change the VAC dressing pressure just because of STIMULAN, but we wait for 5 days. Delay. We don't apply in the operating theater. We give more time. We apply compressive bandage or compressive back slap in the operating theater, well padded bandage, and we give more time. And then when we take the bandage off, some of the beads come off, but that's fine, and we apply normal back dressing in our unit.
Okay, thank you. Well, we finished a little bit early, but we have answered all the questions. So I would just like to thank everybody who is registered for this webinar. We've had over 100 delegates from all over the world. So I want to thank you all very much, but a special thank you to you, Venue, for an excellent presentation and sharing your experience on this topic. Thank you, everybody. Thank you, everybody, and I hope you have a lovely evening.